it becomes a very exciting time when existing technologies that before were science fiction are available to really take the burden off of clinicians so that she is practicing at the highest level of her licensure and doing what she needs to do, which is take care of patients.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. From San Antonio, Texas, we are welcoming Dr. Esteban López. And I could just stop and tell our audience that you're the new market lead of healthcare and life sciences for the Americas at Google Cloud, but there's so much more that we can touch on. However, before we talk about Google type things, Dr. López was a top executive physician leader at Healthcare Service Corporation, the largest customer-owned health insurance company in the United States, operating through the Blue Cross and Blue Shield plans in Illinois, Montana, New Mexico, Oklahoma, and Texas. Welcome to the Business of Healthcare podcast, Dr. López.
Thanks, Bob. Thanks for having me.
We're glad to have you here. And there are so many things I want to share with our audience in this session. But first, I want to cover the concept of physician leadership and the role it's played on your professional journey, and then move into some other exciting topics, which might include, Google Cloud, et cetera. But you were one of the early graduates for the Alliance for Physician Leadership at UT Dallas, where you received your MBA. So what influenced you to take that route early on in your medical career?
Gosh, it's hard to believe that it's at least 15 years since I started that program. And back then it was called the Alliance for Medical Management Education. So some of your listeners may remember it as that. And I remember being a resident and getting some of the mailers, and I did my residency in Houston. And what I realized in residency was I was getting trained to be an excellent physician, but I knew nothing about the business of medicine. And in healthcare at the time, what I saw was a lot of MBAs, a lot of folks with masters in health administration, none of which were clinicians, making decisions for doctors, nurses, and patients. And I thought, well, if I want to have a voice at the table, I have to know more than just the clinical medicine. I really have to understand the business of medicine. And that's how I ended up at UT Dallas.
Well, your path, your journey, leadership-wise, just for the benefit of our audience, you had a stellar role there at Blue Cross Blue Shield. You went from being the president of Southwest Texas to the chief medical officer for Texas to the chief of clinical strategy and innovation. So you were advancing. Did that MBA really make a difference for you? Could you have done all that without it?
Oh my goodness, yes. The MBA got me my first leadership job. So even before I finished the MBA, and let me just be very clear, Bob, I think that clinicians, and specifically physicians, as well as nurses, need to be integrated in all aspects of healthcare, not just seeing patients. They need to be executives at hospitals, at insurance companies, at places like Google, at life sciences companies, at medical device companies, at private equity firms, anywhere that is involved in healthcare. We need physicians and clinicians at the table because only they have laid hands on a patient. They understand what doctors and nurses go through. And if they're not at the table making decisions, then oftentimes those decisions cannot be patient focused or clinician focused or really in the best interest. So yes, to answer your question, the MBA, even when I was a student at UT Dallas, got me my first job at the age of 32 as a medical director of an emergency department down in Harlingen, Texas. And then, I was still in my MBA program when I became a medical director at McKesson Health Solutions. I was 34 years old and spent 6.5 years there while I was still practicing full time. So it was invaluable. And I don't think I would have been recruited to Blue Cross, honestly, to be the president for Southwest Texas at the age of 40 without it.
Well, we're finding today that in our program, we really have the top physician leaders, just like you. That's the people that want to come into the program. We hear a similar story in that you want to be prepared, you want to be confident to be able to sit at the table. And, some of the skills that you learn are so different than what you get in medical school. And from the time you get the long white coat and they call you doctor, and you think that you're going to have a very narrow cast view on just helping patients, somewhere along the line, things became much broader and the view had to be extended in order for you to really reach out and make a difference, because you just can't do it on your own anymore, can you?
You absolutely can't. For me, medicine is a vocation. A lot of clinicians, doctors and nurses think of their career as a vocation, which is very different than just a job or just a profession. And so for me, the work that I do outside of hands-on seeing patients is part and an extension of my vocation as a physician. But you're absolutely correct. I spent my entire 20s in school or in training and knew very little about the realities that healthcare as a business faces. And so it really disempowered me to be able to help contribute in a positive way. Regardless of a healthcare entity is for profit or no profit, if there's no margin, there's no mission. And we need those margins in order to be able to take care of patients effectively. And we need to always look for efficiencies to improve clinical outcomes and operations. And that's not something that you learn in medical school or residency.
Today, Dr. Lopez, we hear a lot about physician burnout. And the reason being is that they're not practicing at the top of their license. They have so many things that they do which are administrative, and it's frustrating. And so finding that balance of how to let those who are leaders in the clinical field lead and those who want to lead in the business side of things is an important differentiation. Have you found that to be true on your journey, that being an administrative leader is a breakaway from this physician burnout situation?
I think it definitely is. I mean, it's a very different situation if I was practicing 5 days a week. I'm still practicing physician, but I'm not practicing 5 days a week, pulling 40, 60 hours a week of seeing patients. I remember the days I was doing that. And yes, that's very hard to do. It's taxing on you as an individual. It takes me to why I'm at Google. And just as a reminder, I'm not here representing Google or my employer, but I can definitely talk about the work that I'm doing there. Google is, why is a doctor like myself, who is a senior insurance executive working in tech now, specifically at a cloud company? Because we're focusing on digital transformation and really to be able to address things like physician burnout. Right now, physicians are slaves to the EMR. I believe the EMR needs to be a slave to the physician. And we have to use technology to be able to do that. And that has to be designed by someone who has taken care of patients, and not just, a data scientist or a software engineer. And while I'm not a software engineer or a data scientist, I am a physician, and I understand the business problems that need to be solved. And that's why I'm at Google, because I bring that sensibility to the table.
Well, right now we're in the middle of a healthcare information and management technology course. And we're talking about these EMRs, these electronic medical records. And we're cussing and discussing them. We're doing both. It really becomes very clear that when you do get the perspective and the insights of someone who's close to the patient and really knows what needs to be done, in conjunction with some of the technology folks, you have a better outcome. And I noticed that you're a lifelong learner, and recently you've taken some executive education on digital transformation at the Harvard Medical School. How did that help you in what you're doing? You're really involved with analytics today?
Yes. Again, I would not consider myself a data scientist or a software engineer, but I know just enough to be dangerous. And so, for instance, as I mentioned earlier, that EMR being a slave to the physician, not vice versa, how it currently is. I have to be charting, and I have to have pop-ups, and I have to have all this information. And why am I charting? I'm charting either because I need to capture that clinical information to the next provider, or because the hospital needs me to capture that information to assess the patient's risk, or because the insurance company needs to assess that information. But imagine, even especially through a virtual journey, that there is an artificial intelligence that is capturing that information through natural language processing and creating voice to text and pulling that information out, essentially the history and physical exam findings that I'm having while I'm interviewing you. And in a virtual visit, the physical exam findings may be what I see over on the screen, and I'm going to make a diagnosis, and I'm going to make a prescription. And all of that can be spoken to you as I would normally speak to you as a patient. And then that actually populates the EMR or generates a prescription Here's the diagnosis that I made, and sends information to you. Those are the capabilities that I believe are available today with the technologies that we have in place. And it becomes a very exciting time when existing technologies that before were science fiction are available to really take the burden off of clinicians, so that she is practicing at the highest level of her licensure and doing what she needs to do, which is take care of patients.
Very well stated. Very well stated. So when we talk to a number of the doctors in our current program, the Alliance for Physician Leadership, they all see Google as a potential positive disruptor in healthcare. So for the benefit of our audience here, I'm going to just jump into the topic of Google. Maybe not even everybody knows that Alphabet's the parent company, and it was set up so that Google could do what Google does, and then we could have all types of other creative outreaches. And it would really be unfair to have you explain all the different dimensions of the various companies that fit underneath that Alphabet umbrella. But we know that Google owns a number of household names like Fitbit and YouTube and Nest. And there's other companies. We actually, one of our podcasts, we're fortunate to have Dr. Vivian Lee from Verily. And that's another Google company. And she featured her book, The Lung Fix. So when we stop and think about Google as a potential disruptor, and here you are with a new position, market lead for healthcare and life sciences. That sounds like a huge undertaking. So tell us what you can about what you've seen and what your role might be along that journey.
Well, one, Google's a great company to work for, and so I feel very privileged to be at Google. Google Cloud is part of Google. So there is Google under Alphabet, and then there's what we call the other bets, and we call them bets. So Verily, Calico, and believe it or not, Google has companies that are dedicated to health. So there's Google Cloud with the branch that I'm in, healthcare and life sciences. There's Google Health, which is doing very interesting work and doing very interesting research as well. There's Verily, as you mentioned, which is doing a lot of work around population health and chronic condition management. Calico, which is doing longevity research, and now most recently Fitbit as part of the Google family. So those are companies that are all they do, they wake up in the morning and think about health. In addition to that, there are over 57 different investments across Google. You mentioned YouTube. Well, there's YouTube Health. Things like maps can be used to help patients get to hospital appointments. There's a lot of different components to Google that are in the healthcare space, but we are definitely committed to being in healthcare and making sure that we're making a difference. And why? Why is Google in healthcare when Google is really people think of it as a search company or a consumer facing company? Google's mission is to organize the world's data. And Google Cloud, where I work, is to organize the world's healthcare data. So that's one of the things that aligns with our mission.
Wow, that's an incredible statement that you just made there. I was familiar with cloud computing. That's not too foreign of a concept. And I went out and looked at Google Cloud, and then particularly in the healthcare area. In researching my time to spend with you today, I found just voluminous amounts of information, videos, white papers from all these different groups. It was just overwhelming. And I don't think our audience knows about that. And I would encourage them to go out and to look at that. There's a recent white paper, COVID-19 and Healthcare's Virtual Transformation by Google, along with Amwell and Becker's Healthcare. I mean, there's a rich set of data out there, and I was impressed to see how that all comes together. And I'm glad to see that you do interact with the other healthcare organizations there. So you're not a bunch of silos. You actually have some inner workings together, I assume.
Yeah, actually, the paper that you just mentioned, I was quoted in that article with regards to some of the work at Google Cloud and Amwell, and I have to be careful because my Google Assistant will pop up if I say the G word, and then we'll start speaking while we're talking on the podcast. But to your point, yes, there is a lot of interesting work in the cloud space, and think of it as a layer cake. And that foundation of that layer cake is the cloud computing platform. And at Google Cloud, it's Google Cloud Platform, GCP. And then you build on that capabilities that specifically will be able to enhance healthcare, be it from the clinical standpoint and taking care of patients, or the operation standpoint, or the billing standpoint. A lot of healthcare organizations have their data warehouse on premises, and they manage that. And a lot of them are, in order to be able to really modernize their infrastructure, are moving to cloud computing, and also to take advantage of what cloud computing can do with their data.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
We try to stay on top of all this news, but recently, Google extended their patient care relationships with Ascension Health. And people said, what does that mean? What's going on there? And our overall assessment of that is that Google can come in and make their data more organized and easier to access and manage. And that's quite an experiment there, and it's getting a lot of attention. And we think it's just the beginning of extending the tools and the technology into healthcare.
Well, think of it this way. So we go through the trouble of entering data in the EMR, we as providers, physicians, nurses, et cetera. And then when we need a prior authorization for an inpatient stay, that EMR data is literally printed out, put on a PDF and scanned and put on a PDF and sent to the insurance company. So that organized or semi-organized data was abstracted in an image, sent to the insurance company, who then needs a real human being to take it off the fax machine, review it, organize it, send it to a nurse who then has to read it on her screen, and then potentially send it to a doctor who she has to read it on her screen. So despite some level of organization to healthcare data in an EMR, insurance companies are still having to manually abstract that information through human eyes, not even receiving it in an organized way. And so we are easily in the healthcare system 20 to 25 years behind, because 80% of healthcare data is unorganized. I mean, even the free text that I put in with regards to patient's history of present illness, right? And so, we have a lot of room, and there's a lot of low-hanging fruit, but I'm excited about that opportunity.
Yeah, efficiency. So
I would say more than efficiency, Bob. I would say outcomes. We can always improve clinical outcomes. When you're seeing me as a doctor, as an internist, you're probably seeing me 30 minutes a year, 2 15-minute appointments if you're lucky, right? So 30 minutes a year, there's a lot of minutes there where I'm not physically seeing you. And so imagine if we can abstract that data through remote patient monitoring or some type of robotic process where your Fitbit device or your Apple Watch sends me information before you actually get sick or sends you information, right? Imagine you have CHF and you're not at a tipping point yet, but it's noticed that even within normal limits, your oxygen saturation went down a little bit and your heart rate went up a little bit. Not a lot to be scary. And it starts predicting, saying, hey, maybe you need to cut down on the salt and the liquids that you're taking without even having to alert me as the provider. It's just coaching you.
Wow, that's incredible. Well, I know this, Esteban, that every physician leader that I've talked to, they have some passion that really drives them, that out of all the things they do, there are certain things that really they take up and they carry the banner forward on. And I've heard you speak on health equity. And today we are made more aware than ever about health equity. Can you help our audience better understand the gravity of this situation and even more importantly, what we can do to be part of the solution?
Well, thanks for bringing that up, Bob. I gave a TED Talk back in 2016 on health equity and social determinants of health when a lot of people weren't talking about it. Most recently, it's gotten a lot of popularity, and hopefully I contributed to that in some way. But, we as physicians have known that certain patients have had negative outcomes. I mean, we're not blind to that. But have we really understood that social structures that are put into place and systems that are put into place, even within healthcare, contribute to those negative outcomes? And both either through implicit or explicit biases. And my goal is not only to bring light to that and to call it by its name, because if you think about negative birth outcomes in Black women, that has nothing to do with how Black women take care of themselves. It has nothing to do with genetics. It has to do with racism. And if we can't deal with racism and the toxic effects that it has on Black moms and Black babies before they're even born, because even a Black woman with a PhD or an MD is going to have a propensity for more negative birth outcomes than a white woman with no high school education. And again, it's not because of income. It's not because they don't take care of themselves. It's because of the toxic effects of racism. And that's an inequity that I think negatively not only affects the lives of Black moms and kids and communities, but affects the lives of all of us. And addressing equity and social determinants of health is not just the right thing to do. It's the right thing to do for yourself as well, because the health of your neighbor and the health outcomes of your neighbor affect your health and your health outcomes. And we've seen that in cities that have good equity scores and bad equity scores. So it doesn't matter that you live in a city where, you might be upper income or you might have good access. But if you look at your life expectancy in comparison to someone who has a better equity score, your life expectancy is going to be lower.
That's very interesting. I actually watched that TED Talk and I found it to be very informative. Those problems weren't caused by genetics. They were caused by cortisol, which is a, I'm not a doctor, so you tell me what cortisol is. It's a hormone.
Yeah. It is a hormone. I mean, as you know, cortisol is a hormone that's oftentimes released, or it's released in labor. And what we see in Black women is oftentimes premature delivery. It can cause vasoconstriction of the vessels in the placenta, when we see oftentimes intrauterine growth retardation, which is just a fancy term for a small baby. And I'm not going to blame it just on cortisol by itself, but there's definitely a weathering effect that cortisol and inflammation is part of in Black people in general. But what was most interesting in the data that I saw for that TED Talk is when we see Black women who come from the Caribbean and Africa, they have birth outcomes similar to white women. But in one generation, their daughters have birth outcomes similar to the general African American population in the United States. So it's not genetics, it's the social milieu that people live in that is affecting that
the anxiety factor then could be part of the anxiety factor. Well, thank you for that. What can we do? What can we do to help mitigate some of this? Is there a prescription you can write for our audience to say, do this or don't do that? What are the little things we might be able to do to kind of help this cause? Because it's certainly important.
Well, I think having these type of conversations, so one, call it by what it is, call it by its name, and identify it head on. Acknowledge that there is systemic structures put into place that create negative outcomes for people. It's not just personal choice, and let's work to break down those structures and rebuild them. Let's understand that we're part of that structure as well in the healthcare system, both from, you'll say physicians, well, I'm colorblind or I'm this and that. We are all trained. I mean, even physicians of color are trained in a system that was systemically racist. And so we have to break down those walls and have those honest conversations. And it's not, I mean, you can see study after study after study that shows that certain populations are disproportionately treated differently than others. Black children get less pain medication for the same fracture that white children will have. White medical students think that black skin is different than white skin when it's not. I mean, there's no genetic differences that are so different from a black person versus a white person. And what makes you black? If your genome is 85 or 75% white and that 15 to 20% black is still contributing to your negative health outcome, then it's not genetic, right? It's social. And so we as providers, we as physicians are not going to solve the issue of racism, but we definitely can put structures in place to address the health outcomes or prevent the health outcomes or deal with the health outcomes that racism brings. The last plug with regards to health equity, let me just finish this, because this is about the business of healthcare. I talked about it being the right thing to do. It's also the right business thing to do. 80% of a person's health outcome and healthcare cost has more to do with the zip code they live in than with the healthcare they receive. So your zip code is more important than your genetic code. So if we really want to address the business issues and the cost of healthcare, we can't ignore social and environmental determinants of health. That's the last point I want to make with regards to that.
That was beautiful. I love that. That's absolutely, I love the message you just said is it's your zip code, not your genetic code most of the time. So, but the last topic I wanted to bring up was the word entrepreneur. And I understand that you are also, amongst all the other things you're doing, you have this entrepreneurial seed. Tell us briefly how that fits into your busy life.
Well, prior to joining Google, I founded my own company after I left Blue Cross and Blue Shield. I founded Hopscotch Health. Hopscotch Health will be focusing on children's healthcare issues, specifically children's urgent care issues. And I like to call myself, or our company, a technology company disguised as a children's urgent care. We are looking to be able to provide an amazing experience for our patients and their families. We're looking to be digital natives on day one and to really disrupt the way that families engage in the healthcare system. We know that millennial moms and Gen Z moms have they're digital natives. They deal with healthcare and all aspects of their lives seamlessly in a digital fashion. And we want to create a digital front door that makes sense to them, that they're used to, and have them engage with us just like they do with their social media platforms and come to us maybe for care or maybe for a clinical question. So we're really excited to get that company off the ground and look forward to see how that progresses.
Sounds like a big step in digital transformation again. So congratulations on that initiative. A number of people from your alumni association, which is now the Alliance for Physician Leadership, will be listening to this podcast. And in the current class of 50 will as well. along with a lot of the other students in our programs at the University of Texas, Dallas, and out across the United States. So I want to thank you again for taking the time to spend with us today and to share these ideas. We've really enjoyed it.
Oh, no, on the contrary. Thank you. I'm proud alumni of the University of Texas at Dallas, Dr. McCracken and the Alliance for Physician Leadership. It has been a program that frankly has changed my life, allowed me to have a scope and reach that, now is in the billions of people, and really set a pathway that I couldn't even dream of.
Very good. Have a great day. Thank you again, Dr. Lopez. We appreciate it.
You too.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.